Welcome back, live stream viewers. How's it going? This is Jessica DeMassa from the GuideWell Insights Lounge here at Singularity University's Exponential Medicine. We're happy to have you with us back in the lounge now for this main stage break. Thanks for joining us. Main stage just let out. The session room is now filing down toward the beach to get their scrubs. I'm not sure if you guys saw that, but earlier this morning we had Shauna Butler, who leads partnerships and outreach for Singularity University, talk about the scrub photo, which is really one of the most iconic pieces of exponential medicine, where everybody gathers on the beach in their blue scrubs and takes this class picture, basically. So that's happening right now outside, and inside here in the Insights Lounge. We want to thank you so much for following us along here and also for contributing on Twitter at #XMed. For those of you who've been watching our lounge interviews during the breaks, and also for those of you who are not familiar, we do have other interviews that are taking place while the main stage is in session. So basically at this point I think we've done about 25, 30 interviews with some of the speakers and the innovators and attendees who've been walking around. And if you want to take a look at those are all up on the GuideWell YouTube channel. So all you have to do is go to YouTube and look up GuideWell, or you can find us directly at youtube.com/GuideWellMHC. But those interviews are amazing, and there's a lot of great information that augmented some of the speakers' talks yesterday that you can find only in these interviews. So take a look at those and go find some of your favorites. I know we've been hearing a lot of buzz about the health disparities panel, and our interview with that panel did go a little bit deeper on some of the topics that they covered in their session. So that's one for sure to check out. Right now, though, we're going to talk to another one of the speakers who participated yesterday, and this is Dr. Stephen Hunt, and he is a co-director of the Piggy Lab and an interventional oncologist from University of Pennsylvania, right?
Yep.
So welcome, Dr. Hunt. It's good to have you. Yeah, we've spoken with you before, and we're excited to see you again.
Year and
we were just
a lot
talking
more innovation
about that.
happening. Yeah.
Yeah. Well, it's exciting to hear, especially when we have repeat guests. It's exciting to hear how far you've come along. And if anybody wants to check out our first interview with Dr. Hunt, you can take a look at that. It is on our GuideWell channel. You just look up the 2016 XMed playlist, and that's there. So you can really, we're going to actually measure how well you've done with your innovations from then till now. So I understand that you spoke about really what's going on in cancer as far as some of the trends and the things that are driving forward a transformation in cancer care. So what's going on? Give us a state of play.
Sure. So I mean, I think everything from innovation that's happening at the level of diagnostics from the very beginning, and that has to do with really screening. So one thing I wanted to talk about was the National Lung Cancer Screening Trial, and that's something where we looked at 50,000 Americans using low-dose CT versus conventional X-ray, and showed a 20% reduction in death when you're using low-dose CT. And so this is something that's just now ramping up. You're going to see it across all healthcare centers across the United States, where we take folks who are at high risk of lung cancer. They have a greater than 30-pack year history of smoking, and we screen them with low-dose CT. But this comes at a significant cost. This is somewhere between $28 and $34 billion that's going to be invested in this. And that investment is going to save a lot of lives, but it's also going to create I think some bottlenecks in the system and some difficulty relating to how do you deal with all these new cancers, just like happened with mammography in the late 70s, where a lot of women now are getting earlier diagnosis of smaller stage cancers. So this is definitely going to impact care. Of course, the number one modifiable risk factor in lung cancer is stopping smoking. We still have about 37 million Americans who are active smokers, and that increases to about 100 million Americans who are active or former smokers. So we really need some investment in how do you help with smoking cessation and have a big impact there, because if you look at the dramatic declines that have happened in lung cancer deaths since the 1990s, that has to do with really the reduction in smoking rates. And so there's a lot of innovation I think that's going to happen around behavioral modification strategies and technologies related to that.
Which is interesting because you have been dealing with this for such a long time, and so it's interesting that this is still something that's a topic of conversation, and that innovation is still, like, I guess, looking to take hold there and maybe move the needle even further.
And so when you think about, so they've done actually these studies demonstrating that a $3 billion investment in intensive counseling related to smoking cessation, a $3 billion investment would have the same number of quality adjusted life years, about 900,000 would be saved, versus the $34 billion investment in screening. So that's something that we really need to look at that space and get more innovation involved there. The other big things that I talked about yesterday was precision genomics. So you think about companies like Grail, you think about companies that are in that diagnostic space. They're particularly a company focused on circulating tumor DNA. But all of these companies in that space are looking at deep sequencing of cancer genomes, comparing that against the Cancer Genome Atlas, which is this big project related to sequencing the cancer genome, and then looking for actionable intelligence. Can we predict which drugs to put the patient on, which patients need chemotherapies, which patients don't, what dose of chemotherapy? In our lab, we've taken a little bit different tack. Instead of starting with, let's start with all of the mutations that are present in the cancer cell, what we say is, let's actually go out and CRISPR. This is a new technology you're going to hear a lot about. CRISPR out the genes that predict which drugs you're going to, so it turns out there's about 1,450 drugs that have been approved by the FDA over the course of the lifetime of the FDA. Those drugs channel through about 250 genetic pathways, and you can knock out those individual genetic pathways using CRISPR, and from that you can predict response to drugs. So some of the earliest screens that we've done in liver cancer have demonstrated, for example, one of the earliest screens came back as ornithine decarboxylase, this protein I never heard of. There's a drug
you said it very well.
Yeah, there's a drug for postmenopausal hirsutism. So it's a very small market for women who grow hair on their face after menopause, but this drug is actually specific for this patient's cancer, and no other patients with HCC have that sensitivity. And it's not a gene that's mutated, it's not a gene that's increased in amplification. It's just that cancer cells with all of their various mutations became completely reliant on having that gene present. And so that's where you can take and repurpose drugs that are already approved out there. And so drug repurposing is another one of those trends. And so I think you're going to see that CRISPR really profoundly impact the cancer space.
Okay, so I want to stop there for a second and just ask you, because I mean, CRISPR is such new technology, and the learning curve around that. How is that going to impact the broad scale adoption to that? You know, I mean, you have people in research institutions like yours who are able to do these things, and they may seem commonplace because you've been dealing with them for a few years, but in the local or regional cancer center, are they going to have access to this kind of technology?
Well, I think that it's going to be the person who can finally commercialize that and make a viable company out of it is going to have a Grail-like impact in the field, which is to say that patients are going to be sending their samples. So one of the big things, another trend I talked about was patient-derived samples. We are now able to take our patients' cancer cells, take them out of their body with a biopsy, grow them in what's called a patient-derived xenograft mouse, as well as in a lab dish, and then separate them out, do the deep sequencing on their individual cancer, do this CRISPR screen on it, and so that's going to become a commercial product. When that is commercialized, everybody's cancer is going to have this kind of screening done to see whether there's a drug off the shelf that we can use for their cancer.
How far are we from that being a standard of care?
I think that we're not very far at all. That's how fast CRISPR is moving.
That's incredible, because I was expecting you to say something like, I don't know, several decades away.
No, we're not decades away. We're literally within 5 years of that becoming at least at the level of clinical trial, trying out the new drugs in patients.
That's fantastic.
Yeah.
And so what else? What else do you have your eye on here as far as those cancer trends are concerned?
Sure. I think that image-guided therapies, you know, I'm an interventional oncologist.
What is an image-guided therapy? Like, put that in context in your world.
So for example, all of the cancer treatments that I do, I'm not actually looking physically at the cancer like a regular surgeon does, like opening up the body and cutting the cancer out. What I do is I have the patient in a big camera, like a CT scanner or an MRI. And then what I do is I put the devices into the cancer and either freeze it or microwave it or put some kind of energy in there, as well as doing biopsies. And so that is, that is one of the trends. But you're seeing that with optical molecular imaging. I see that in the standard surgery space. Optical molecular imaging. That's and we're using hyperpolarized MRI. Just all these new ways of imaging. PET-based biopsies and therapy and surgeries. So all of these things are ways in which we can actually look inside of the body without destructively having to open it up, leading to minimally invasive kinds of surgeries.
With all of these innovations, I mean, and these things are fantastic, and what you're describing is, it could be the end of cancer, right? But I want to know, taking a step back to the surgeon or to the doctor, the oncologist, how does medical training need to change to accommodate this type of innovation? Can it change fast enough?
That worries me as well. I mean, I think that we need new learning models for how we're training. You've seen some of that with, I go around the world, right after our conference last year, I remember I was on my way to Nepal at the time to teach minimally invasive therapies in very remote places with very simple tools. And so those are the kinds of things where remote surgery and remote procedures, that's something that's taken over, where we can have medical education around the world. So it's not just about what's happening in the United States and the way in which we're going to adapt our learning paradigms here, but how are we going to train 250,000 surgeons around the world that we need right now, today, and how are we going to increase the workforce? Because as we have a huge population aging cliff that's happening, how are we going to get enough people into the field doing the procedures that need to be being done for cancer? And
one last thing, we've got a few minutes here, so quickly, I want to just give you an opportunity to talk to me about what we discussed before about the silos, the research and the data all being in silos. Now, how do you, as far as that's concerned, what needs to happen there in order to like really break this down so that everybody not only has access to the technology, the right training, but also to the data that they can learn from?
And so I think a couple things. One thing at the funder level. So for example, there's a Sean Parker immunotherapy fund that we got started at University of Pennsylvania. And one of the rules of the money is that we're going to break down the silos. People are going to be sharing the information. This is going to be cross-institutional. Sure. So part of it is going to be the funders themselves. The NIH is going to require it. The individual private foundations are going to require it, et cetera. But I would say even an even bigger driver than that is these patient networks, these patient support networks. So there's actually cancer social media out there. So there's new social media platforms specific for cancer. And one called I Had Cancer, for example. And the patients get on, they come into me all the time, they say, how about this immunotherapy trial? How about this clinical trial? They are very motivated with their disease. They share information, they learn about things. I get patients from all over the country who come to me to get treated because they've heard about the therapies that I do at University of Pennsylvania. So that I think the social media aspect of it, and these cancer support networks, whether it be the Susan B. Komen for the Cure or any of these other networks, we also have really patient-centered outcome. So how do we know that we're treating the things that the patient really wants us to be treating? And so there's obviously the PCORI, the patient-centered outcomes research that's happening at the government level, but these things are starting to trickle down more into the academic institutions as well.
Thank you so much, Stephen Hunt. Thank you so much for all of this perspective. And for those of you who want to weigh in on this conversation, you can do so, please, at #XMed. We are reading those tweets, and they are definitely impacting the way that we're shaping our conversations here. The other thing I wanted to say too was that we've got some great partners, and so I know we have a lot of people following us along from the American Cancer Society. So if you've got anything that you want to chime in, please do so. It'd be great to hear your voice as well. Thank you so much, Dr. Hunt. It was lovely to speak to you. Thanks so much.